Good morning, everyone. Welcome along today to our Insight Upside webinar. I'd like to start off by acknowledging the traditional owners and custodians of the land on which we are presenting today. So for us here in Meanjin, that is the Yagara and the Turrbal people. I'd also like to pay my respect to elders past, present and emerging, and I'd like to extend that acknowledgement and welcome to any Aboriginal or Torres Strait Island peoples who might be joining us today. So my name's Tracy Swan, and I'm one of the nurse educators here at Insight. Today I have the pleasure of introducing Olivia Dobson, who is a research officer at the Matilda Centre at the University of Sydney. And she's going to be presenting to us the results of a recent study examining Australian practitioners' perspectives on prescribing medicinal cannabis. Before we get started though, a little bit of housekeeping. I think most people are quite comfortable with Zoom these days, but if you have any issues, just let us know. Just put a little note into the chat and we'll see if we can assist you. Also, we're going to have some question time at the end of this presentation. So if you have any questions or if you think of something throughout the presentation, just pop it into the chat and we'll come back to that at the end. All right, well, thank you very much. And I'm going to hand over to you now, Olivia.
Hi, everyone, and thank you for the introduction, Tracy. I feel really fortunate to have the opportunity to share this work with everyone today, and I'd be really interested to hear any thoughts or comments or questions that you have throughout. So we conducted this research project on the factors influencing medical practitioners' delivery of medicinal cannabis at Monash University, and it was co-authored by Michaela Barber, Mfanui Graham, and senior authors Associate Professor Adrian Carter and Dr. Michael Savage. It's now been published as an open access paper in Drug and Alcohol Review. If anyone would like to have a read of it later, I've got the link in the start and the end of the slides. I'd also like to thank the contributions of the medical practitioners who generously gave their time to participate in an interview for this qualitative study. And also a thanks to Tracy again for opening us up with the acknowledgement of country. This work was conducted on the traditional lands of the Australian Aboriginal Kulin Nation, and I wanted to acknowledge the traditional custodians of the unceded lands on which Monash University is located. I'd also like to acknowledge the traditional owners of the lands on which I'm zooming in from today, the Gadigal people of the Eora Nation, and pay my respects to elders past, present, and emerging. To start, I'd like to speak briefly about why this topic might be of interest or relevance to those of you here today. As you're likely aware, there is a rising prevalence of the use of cannabis for medicinal reasons in Australia. The National Drug Strategy Household Survey 2022 to 2023 indicated that at least 3% of the Australian population, which is approximately 700,000 people, have used cannabis for medicinal purposes in the past 12 months. And the number of people accessing medicinal cannabis through a prescription from a doctor has actually increased tenfold since the last National Drug Strategy Household Survey, which was in 2019. In the most current survey, 1 in 5 people actually reported always having their cannabis used for medicinal purposes prescribed by a doctor. In light of this, the Australian context really does provide quite a unique backdrop to examine the current factors influencing medical practitioners' medicinal cannabis prescribing behaviours. And there's a couple of reasons why practitioner perspectives in the Australian context is so important to capture and to examine right now. Firstly, there has been significant patient interest in the use of medicinal cannabis in Australia to treat quite a wide range of conditions, likely due to the influence of patient advocacy groups, extensive media coverage about the benefits and the safety of medicinal cannabis, and a growing body of research examining treatment efficacy. However, the evidence base to support the use of medicinal cannabis does still remain quite controversial. While there is emerging evidence which suggests therapeutic effects for some conditions, these findings are heterogeneous across studies, and much of the scientific evidence on medicinal cannabis is obtained from observational data or from open label studies, rather than from the gold standard randomized control trials. There is still a need for more rigorous evaluation and comprehensive pharmacovigilance approaches to better characterize the efficacy and the long-term safety of medicinal cannabis. Although real-world sources of data do show that patients report improvements in symptoms across a wide range of conditions, including pain, psychiatric, and neurological indications. Although this evidence base is still growing, this really strong patient demand in Australia has sparked legislative change, which allowed therapeutic use of medicinal cannabis to largely circumvent the research and regulatory processes typically necessary before widespread integration of a pharmaceutical into clinical practice. Access to medicinal cannabis is relatively new in Australia, with the government legalising a framework only in November 2016. However, almost all current available cannabis-based products are classified as unregistered medicines by the TGA, as they haven't undergone the rigorous assessments of safety, quality, and efficacy, which would allow entry into the Australian Registry of Therapeutic Goods. As a result of this, patients must access medicinal cannabis through a prescription from a medical practitioner via two primary pathways, which are both regulated by the TGA. The first is the Special Access Scheme, which allows a practitioner to apply to prescribe a product for a single patient on a case-by-case basis. The other main pathway is the Authorised Prescriber Scheme, which allows practitioners to apply for authorised prescriber approval for a specified cannabis-based product for a particular indication. Therefore, the second reason that Australia is quite an interesting context to examine practitioner attitudes is that practitioners are essentially the gatekeepers to patients accessing medicinal cannabis under our current regulatory framework. Finally, data captured by the TGA shows a recent surge in applications from practitioners to prescribe medicinal cannabis through the special access and authorised prescriber schemes, particularly since 2020. So the graph on the screen is an analysis from McPhail and colleagues' 2022 paper, where they found that the number of Special Access Scheme B approvals has been increasing in a non-linear pattern over time, with a really dramatic increase from 2020 to the end of the analysis period in 2021. And this trend definitely does not seem to be slowing down, with TGA data showing that over 500,000 applications to prescribe medicinal cannabis have been approved through this pathway to date, and this doesn't even capture prescriptions from authorised prescribers. Applications to prescribe have been approved for almost 150 unique indications, primarily pain, anxiety, sleep disorders, and cancer and related symptoms. What's really interesting here, though, is that this is quite a contrast to the really low rates of prescribing that we saw in the first 3 years following implementation of the Access Scheme, with under 30,000 applications to prescribe before 2020. In fact, a 2020 Senate inquiry investigating concerns around patient access to medicinal cannabis actually concluded that practitioner unwillingness to prescribe was a significant barrier to patient access. We can make sense of these low rates when we turn to previous survey and qualitative literature on the topic. With both Australian and international literature having found very, very consistent evidence that although practitioners are receiving frequent patient inquiries for medicinal cannabis, the majority report being uncomfortable or unwilling to prescribe, citing quite a few barriers, including poor knowledge, insufficient evidence to support use, and concerns about adverse effects and patient harms. However, as no data has been collected on practitioners' experiences, beliefs, and attitudes towards prescribing medicinal cannabis in Australia since 2020, it's not really clear at the moment what might be driving this apparent increase in practitioner willingness to prescribe. Based on this, we did identify that updated research was needed to answer some of these questions, and particularly to examine the perspectives of those practitioners who do choose to prescribe within their practice. Questions about the motivation, opportunity, and capability of practitioners to prescribe medicinal cannabis really drove the research question for this study, which was to examine the factors shaping medicinal cannabis prescribing behaviours for Australian practitioners. There's also been numerous calls to draw on the extensive body of behaviour science theory when looking to understand medicinal cannabis prescribing behaviours. And so to address this gap, we based our research on the theoretical domains framework, which I'll call the TDF for short, just for ease moving forwards, which explores the cognitive, affective, social, and environmental influences on prescribing behaviours. The TDF is a really well-validated framework designed to systematically examine barriers and facilitators to behaviour change among healthcare professionals. And it basically synthesizes 33 theories of behaviour change into the 14 domains that you can see on the screen. I'll really briefly touch on these as I present the results, but if you're interested in the application of behaviour science to healthcare provider behaviour, I really do recommend looking further into these domains. To provide you with a really brief overview of the qualitative methods that we used in this research, we conducted semi-structured interviews in 2022 with 17 Australian practitioners to identify the factors influencing medicinal cannabis delivery. The interview schedule was informed by the TDF in a way which aimed to first explore the most salient barriers and facilitators for prescribers before prompting the exploration of all other domains. Participants were selected through purposive sampling and had to be registered with the Australian Health Practitioner Regulation Agency and, of course, be able to prescribe medicinal cannabis. Our final sample was largely male and over the age of 45 years and included psychiatrists, nurse practitioners, medical specialists such as in sleep medicine, neurology and gynecology, a junior doctor, general practitioners, and practitioners who worked in private practices dedicated to prescribing medicinal cannabis, who we've labelled as cannabis specialists for the purpose of this work. There was quite a range of levels of experience prescribing medicinal cannabis in the sample, with 5 of our participants having no experience prescribing in the previous 12 months, and 6 having quite extensive experience, having prescribed medicinal cannabis over 500 times in the previous 12 months. Interviews were recorded and we analysed transcripts using the framework approach to thematic analysis, which allowed us to generate themes both inductively from what emerged from the data and deductively based on the TDF framework. So following the creation of the thematic framework, we mapped the content of each theme to the appropriate TDF domain. Now to jump into the results, the first factor that we identified as influencing prescribing decisions was the clinical capabilities needed to prescribe medicinal cannabis. And this was related to the TDF domains of knowledge, skill, memory, attention, and decision-making. All practitioners in the study cited a widespread lack of knowledge and resources to guide effective prescribing, describing medicinal cannabis as largely outside of the mainstream of medicine, with limited traditional avenues available for learning, such as tertiary education, professional development courses, or even just through observing and learning from supervisors or colleagues within the clinic. As a result, there was a view that many practitioners in the medical community lacked really the basic knowledge needed to prescribe, including understanding pharmacology, available products, dosing, adverse reactions, and contraindications. Those who had quite frequent experience prescribing medicinal cannabis actually described acquiring their knowledge through self-directed learning outside of work hours. But concerningly, although they did tell us that there was a huge amount of information available online about medicinal cannabis, it was quite challenging to identify which sources were unbiased and credible. Of particular note, they felt that information being disseminated by peak industry bodies and regulatory agencies in Australia was just insufficient to inform their prescribing decisions, particularly for a lot of the conditions that patients would frequently inquire about, including psychiatric conditions such as depression and anxiety. In quite a similar vein, a major barrier to prescribing noted by all participants was the lack of guidelines for identifying the most suitable treatment approach for individual patients. What was quite interesting here was that participants with limited experience prescribing largely attributed this to the complexity of the cannabis plant, as well as the fact that there was limited data available to demonstrate which products, preparations, and dosages were most effective across indications. Comparatively, many of the practitioners with extensive experience prescribing actually felt that they had observed a lot of individual variation in the effects of cannabis-based products from their patients. And they really felt that a one-size-fits-all guidelines-based approach was just not possible for medicinal cannabis, and that it required a really tailored treatment and a lot of trial and error in close collaboration with patients to find the right treatment approach for individuals. In our second theme, participants consistently identified three barriers to prescribing, which were related to medicinal cannabis's status as an unapproved therapeutic good. This theme was mapped to the TDF domain's environmental context and resources and beliefs about consequences. The first barrier was that the prescribing process was seen as highly time-consuming due to the need to apply via the special access scheme or to become an authorised prescriber. One GP actually told us that they had chosen to establish a separate private practice dedicated solely to prescribing medicinal cannabis to their patients, as it wasn't feasible for them to prescribe in their primary GP workplace due to consultation and administrative limits. The second barrier was prohibitively high cost of medicinal cannabis products in Australia, with patients required to pay hundreds of dollars per month for their medicine, which made it really difficult to recommend medicinal cannabis over other comparatively affordable and subsidized pharmaceutical options. This, of course, was a particularly significant barrier for those working with patients from lower socioeconomic backgrounds. Finally, participants were actually concerned about potential legal repercussions or adverse outcomes from prescribing an unapproved therapeutic good. The most common concern about legal liability was actually a concern that patients would drive while under the influence of THC and claim that they weren't properly informed of the dangers by their prescribing doctor. In our third theme, we identified that negative attitudes towards medicinal cannabis prescribers within the medical community also acted as a barrier to prescribing. While all participants did identify that there was an overall positive and accepting shift towards medicinal cannabis and that those attitudes were changing within the industry, most did note that there was still a degree of stigma associated with actually prescribing it. In fact, those with extensive experience prescribing felt that many in the medical community did not consider medicinal cannabis to be a legitimate therapeutic option, and that those who did prescribe were seen as engaging in pseudo-recreational or unsound medical practices. We even heard from two participants who were a GP and a cannabis specialist that they had experienced verbal abuse from other treating clinicians due to prescribing medicinal cannabis for a patient under their care. A concern that actually arose from numerous participants who prescribed was that negative attitudes towards medicinal cannabis prescribers was being reinforced by the actions of some practitioners in the community who were perceived to be falling short of the minimum standards of patient care and prescribing with necessary caution. They particularly referenced really large medicinal cannabis clinics prescribing to patients without taking an adequate medical history and charging really very high prices for consultations, as well as having perceived financial ties with medicinal cannabis dispensaries. These patients did contrast such an approach with the high standards of care that they personally felt they upheld in their practice, but they were worried about a lack of differentiation between the good and the bad medicinal cannabis prescribers within the broader medical community. And in our final theme, we identified that beliefs about clinical utility appeared to be a highly influential factor in guiding prescribing decisions, which aligned with numerous TDF domains, including beliefs about consequences, social and professional role and identity, intentions, and goals. Interestingly, we actually captured two very different beliefs about clinical utility, even within our sample. And the first came from a minority of participants who expressed uncertainty about the clinical utility of medicinal cannabis. These participants were primarily male, and over the age of 45 years, working in metropolitan areas and in specialists areas of medicine. These practitioners cited limited evidence to support the use of medicinal cannabis for only a very small number of clinical indications, including intractable childhood epilepsy, chronic pain, and nausea and vomiting. These patients didn't actually dismiss the possibility that medicinal cannabis could be of benefit to their patients. And even some of them did note that they did observe some patients who appeared to benefit from medicinal cannabis that was self-medicated or sourced from other practitioners. However, they really did emphasize the need for scientific evidence to confirm these benefits, citing potential biases which could influence patient-reported benefits. As a result, and as you might expect, these practitioners did not wish to prescribe themselves or would only prescribe as a last resort treatment. And in line with this, all had no or very limited experience prescribing. They perceived this to be really congruent with their professional identity and their values as practitioners, emphasizing that science rather than patient demand or emotion should guide clinical decision-making. But interestingly, despite not wishing to prescribe themselves, these participants did note that they were comfortable referring their patients to other prescribers with perceived expertise in medicinal cannabis, which may be related to the fact that these participants expressed a view that medicinal cannabis was a fairly well-tolerated and safe therapeutic option. This also aligns with the experience of more experienced prescribers in the study, who noted that they were frequently referred patients by other practitioners who were unwilling to prescribe themselves. In contrast, the majority of participants in this study actually held a really strong belief in the clinical utility of medicinal cannabis for their patient populations. The 12 participants with this view were quite diverse in age, professional background, workplace remoteness area, and gender, although most did work in the private sector. Rather than viewing medicinal cannabis as a curative treatment, they described it as providing symptomatic relief and improving the quality of life of their patients by allowing them to engage in occupational, social, and recreational activities. In this way, medicinal cannabis was considered an extremely valuable tool in their clinical toolbox for helping patients with chronic long-term conditions, as it was perceived to help them manage and live with their illness. Many of these practitioners did acknowledge that there was limited gold standard evidence for many of the conditions that they had personally observed the benefits of medicinal cannabis for, but they described the persuasiveness of the first-hand observations that they saw day to day in the clinic from patients across a really diverse range of indications. Thus, prescribing was viewed as highly congruent with their role, their values, and their ethical responsibility as practitioners. This was actually a very, very influential facilitator for prescribing for these participants, with some even describing somewhat of a professional responsibility to prescribe, to not only allow their patients to access medicinal cannabis, but also to legitimize it as a therapeutic option and reduce barriers of access for practitioners and for patients alike. After that summary of our 4 themes, I wanted to take some time to unpack these results and bring our findings together. Our application of the TDF facilitated a comprehensive examination of the factors influencing medicinal cannabis prescribing decisions, and we found that 9 of the 14 domains were actually relevant and seemed to influence prescribing behaviours, which really underscores the interplay of the multifaceted factors which influence practitioner capability, opportunity, and motivation to prescribe. From these findings, we drew several conclusions which we hope can inform future policy and practice in this really novel area of medicine. Firstly, despite the rapid increase in number of applications to prescribe, it's clear that pervasive barriers do still exist to prescribing medicinal cannabis, which limits practitioners' capability and opportunity to prescribe. Many of these factors have been previously highlighted in the literature, including limited baseline knowledge of the clinical or pharmaceutical aspects of medicinal cannabis, challenges in identifying reliable and unbiased sources of learning and information, challenges in determining appropriate treatment approaches without clear guidelines or data to inform these decisions, particularly considering that there's over 400 cannabis-based medicine products currently available in Australia, a burdensome application process under the current Special Access Scheme regulatory model, and of course, prohibitively high costs for patients. Although it has previously been captured that practitioners are concerned about the medico-legal liability associated with prescribing an unapproved product, it was particularly novel in this study that we found that the primary concern was being liable for patients driving with detectable levels of THC in their system, which is an offence in the majority of states in Australia. Although it's been widely highlighted that current presence-based cannabis drug driving offences are a key barrier for patients seeking medicinal cannabis as a treatment option, our findings suggest that these laws may also influence practitioner willingness to prescribe also. We also identified that negative attitudes towards medicinal cannabis prescribers in the community acted as a barrier to prescribing. And to our knowledge, this was the first study to document prescribing practitioners' experiences of judgment and disesteem within the profession, providing a little bit of insight into the role of social factors in influencing prescribing behaviours. These barriers largely are related to inherent challenges of legalizing a therapeutic before establishing robust evidence of efficacy and safety, and really emphasize the need for ongoing government investment in well-designed clinical and pharmacological studies. However, in the meantime, as the evidence base does continue to develop, we may need rapid translation of research findings into educational resources in order to support care decisions. Prescribers may need to also cautiously leverage other forms of knowledge, such as real-world sources of evidence. Secondly, we found that professional identities were highly influential in shaping prescribing decisions and acted as either a significant barrier or a significant motivator to prescribing. We did observe those two divergent beliefs about the clinical utility of medicinal cannabis, which appeared to be highly related to ideas of professional identity and ethical practice. First, we had the minority of participants who expressed uncertainty about the clinical utility of medicinal cannabis, citing a lack of rigorous studies to confirm its efficacy for their patient populations. This may be related to the epistemological position of mechanical objectivity, which underlies the principles of evidence-based medicine and emphasizes the need for standardization and quantification over and above human subjectivity. As there is limited gold standard evidence to support the use of medicinal cannabis for many of the indications that patients appear to be interested in using it for, prescribing may be viewed as incompatible with the standards of evidence-based medicine. While this did represent the minority perspective in our sample, previous studies have consistently found that the majority of practitioners do desire more robust evidence of efficacy before prescribing, and this discrepancy could be attributed to our study sample, with many of the participants having extensive experience prescribing. In contrast, the participants who held the very strong belief about the clinical utility of medicinal cannabis did acknowledge a lack of gold standard evidence, but reported relying on experience-based knowledge, which may reflect a more experience-based approach to prescription, in which practitioners test clinical utility in their practice and interpret the evidence base in light of these experiences. From this perspective, clinical observations and patient-reported outcomes are valid forms of evidence, and prescribing medicinal cannabis could be seen as fulfilling a clinician's obligation to provide patients with beneficial treatments and to alleviate suffering. These participants' beliefs about the compatibility of prescribing with their professional identity appear to be really influential in their uptake of medicinal cannabis within their practice, and was the only facilitator that we found in this study amongst quite a lot of barriers. Many actually noted that these beliefs were what gave them the motivation to push through these barriers, such as by seeking out self-education within their own time or obtaining authorized prescriber status. Although really positive views towards the clinical utility of medicinal cannabis have been documented amongst US and New Zealand practitioners and do reflect patient reports on the benefits of medicinal cannabis, to our knowledge, this study is the first to capture this perspective among Australian practitioners, and it gives us some really good insights into potentially the driving motivators behind the recent exponential increase in applications to prescribe, despite the pervasive barriers to prescribing still existing. These findings further support previous work which indicates that medicinal cannabis seems to challenge these two competing professional identities for practitioners: adherence to biomedical standards versus the strong desire to alleviate pain and suffering in patients. The conflict between these identities is also reflected in wider debates about medicinal cannabis, particularly regarding what constitutes valid evidence and how we can work towards policy which ensures both safe and equitable treatment access. And lucky last, our findings also indicate that prescribing practices do not seem to be uniform amongst Australian practitioners, with participants with those strong beliefs having extensive recent experience prescribing, being between 50 and 1,000 plus prescriptions in the past 12 months, often in a private practice dedicated to medicinal cannabis. These participants describe themselves as actually possessing unique clinical skills related to medicinal cannabis and reported receiving frequent patient referrals from other practitioners unwilling to prescribe. Interestingly, even participants who expressed uncertainty about the clinical utility were willing to refer patients to these perceived experts in the field. And while this is, of course, tentative, these findings could suggest the emergence of a new specialization within the Australian healthcare system, where patients seeking medicinal cannabis prescriptions are likely to either contact or be referred to practitioners who solely provide medicinal cannabis therapies. Recent evidence from the Cannabis as Medicine Survey 2022 does seem to support this, with around 80% of participants with a medicinal cannabis prescription reporting that they obtained it from a dedicated medicinal cannabis clinic. Specialist medicinal cannabis clinics have become common internationally due to the general reluctance of practitioners to prescribe. But this is a relatively atypical trend, as practitioners typically specialize in treating either specific conditions or bodily systems rather than in using a specific pharmaceutical. Because of this, the role and the impact of medicinal cannabis specialists in the Australian healthcare system is largely unknown. Participants in the study did emphasize some potential benefits of such a specialization, which could include treatment approaches tailored to individual patient needs, the provision of a safe, non-judgmental space for patients to discuss medicinal cannabis, and increased accessibility, which may reduce the necessity to seek cannabis for medicinal purposes via non-legal pathways. However, there are some risks to an emerging specialization of medicinal cannabis prescribers, which should be considered. These include the potential fragmentation of care for patients with complex clinical conditions, as well as costly consultation and monitoring fees, and the potential for dual roles to emerge when cannabis clinicians have commercial stakes in the product that they prescribe. Participants in this study actually did perceive that the medicinal cannabis industry in Australia was rampant with what could be described as bad actors, including practitioners who held conflicts of interest due to financial interests in certain medicinal cannabis products, or who were perceived to not adhere to minimum standards of patient care, such as taking adequate medical histories to ensure that medicinal cannabis is a safe and appropriate treatment approach, as well as kind of not providing continuity of care and monitoring symptoms. This was also viewed as potentially perpetuating stigma towards medicinal cannabis and those negative attitudes towards those who prescribe it, which we noted in this study. And this has the potential to continue to entrench polarized professional identities and discourage prescribing among practitioners outside of this niche, such as a patient's usual care provider. You might know that, You might know that this topic has been receiving significant media attention recently, with peak bodies such as the Royal Australian College of GPs expressing concern over the growth of one-stop medical cannabis clinics. The TGA has also issued upwards of $600,000 in fines, including to medicinal cannabis clinics for unlawful advertising of these prescription-only medicines directly to consumers via their website or social media pages, which is a violation of the Therapeutic Goods Act 1989. Our findings further highlight that consideration should be given to how an emerging specialization of medicinal cannabis prescribers may influence patient healthcare outcomes. For example, there might be a need for implementation of systems to ensure comprehensive monitoring of safety-related and therapeutic outcomes with medicinal cannabis prescriptions, or monitoring to ensure that standards of care are being upheld. We've also identified a need for future research examining Australian patients' experiences with being referred to or receiving care at specialist medicinal cannabis clinics, as the important perspectives of patients have been largely uncaptured to our knowledge. To provide a really quick summary, our findings provide new insight into the multifaceted factors influencing practitioners' delivery of medicinal cannabis and provide further context into the recent trend of increasing applications to prescribe in Australia. The findings also give us some broad insights into the factors that influence successful implementation of any new innovative medicine into practice, which include clinical capabilities, challenges associated with the regulatory status of the therapeutic, perceptions of the therapeutic within the medical community, and differing beliefs about clinical utility and how this links to ethical and professional responsibilities. These factors give us a bit of a framework of both the drivers and the barriers which impact practitioner uptake of innovative medicines, particularly where strong patient demand precedes robust evidence of safety and efficacy, such as the use of e-cigarettes for nicotine replacement therapy, for example. And are also relevant for other drugs that have both illicit and medicinal uses, like psychedelics for the treatment of anxiety and addiction. We really hope to continue to see attention drawn to the factors identified in this study, with, of course, the overarching hope to improve safe, appropriate, and effective patient access to innovative and potentially contested medicines, including medicinal cannabis. So thank you very much for your attention, and please let me know if you have any questions or thoughts or comments. I see a couple in the chat already. We'd really love to hear them and have a bit of a discussion about what you think about the topic. I've also included a number of references in the slides if anyone's interested in reading more work in this area. Thank you.
Thanks, Olivia. So we've got a lot of comments just saying how wonderful that was, and it really was really good information there to find out. As you said, we have got some questions, so if we can just go through those now. We had some questions about the stigma. So you sort of touched on the stigma within sort of like the professional circles, sort of like the practitioners and each other sort of thing. But does the prescriber's own sort of stigma? Is there those sort of prescriber stigma blocking it as well?
Self-stigma towards themselves?
Yeah. Well, no, more about, cannabis itself. Cannabis is an illegal drug. Cannabis is not, people who use cannabis are not right, not using it for right purposes sort of thing. We do sort of see that in the AOD field, sort of that stigma. Did that come across with you talking to prescribers?
It definitely did. Interestingly, for the group of practitioners who hadn't prescribed, they did feel that they had a fairly destigmatized view towards cannabis, and they didn't perceive that any of their colleagues would avoid prescribing medicinal cannabis for potentially stigmatizing reasons. However, interestingly, the practitioners who did frequently prescribe, they admitted that they had to do a lot of work themselves to get over these stigmatizing attitudes. And interestingly, a lot of them were over the age of 50, 60, and they kind of grew up in the era of reefer madness, and they consistently referenced having to do work to acknowledge and move past their biases. But it is quite interesting that they were able to reflect on that and incorporate medicinal cannabis into their prescribing practices very frequently, despite potentially strong biases, even 5 or 10 years ago.
Yeah. As you're aware, sort of a lot of our listeners and people out there who've joined us today are working in the AOD treatment field. So do you have clients that have been prescribed medicinal cannabis and they have to stop, or other doctors talk about problems with people having to stop cannabis if they are looking for treatment for other things, or if they have prescribing issues, those sorts of things?
Yeah, that actually didn't come up in our interviews, and I'm personally not a practitioner, so I don't have personal experience. Although what was quite interesting was this continued reference to cannabis as being a safe and well-tolerated medicine, and
Mhm.
particularly in comparison to other treatment options for pain, such as
Yep.
opioids. There was a view that kept coming up that cannabis was a really safe and well-tolerated option, and there was very little talk about potential harms or addiction or side effects. It was definitely seen as a safer alternative to other medicines, which I think is interesting to give us a bit of insight into where practitioners' heads are at when they're comparing harms to other treatment approaches.
Yeah. Yeah. So was there sort of like a difference in willingness to prescribe, if the person was already using illicit cannabis, for example, or if they were saying using the illicit cannabis for their medical problem, or because they wanted to access the medicinal to reduce the harms of illicit cannabis use? Was that sort of an issue, or?
Yeah, I'm careful of the way that I word this, as were the practitioners that we spoke to. It didn't seem that providing a legal pathway to cannabis was a motivating factor in terms of allowing people to stop accessing illicit cannabis, but it was definitely described as a benefit in terms of providing that tailored care and ensuring that products were safe and that we knew what was in them, and of course issues related to potential contaminants. So while that wasn't described very cautiously as a motivating factor, it was definitely seen as a benefit for practitioners that did prescribe, in that they were able to work with their clients who already wanted to use it for medicinal purposes and make sure they do it in a safe and monitored way. Although, of course, there was concerns that this wasn't the case for all practitioners out there prescribing medicinal cannabis, and even potentially for a large chunk of practitioners.
Yeah.
Mm.
We've got Jeremy, who's a doctor up here in Queensland. He's asking about the SAS. He said he's never had any applications declined. Is there really a purpose to this application process?
Yeah, that's really interesting too. They do publish that data on the TGA dashboard, and from what I recall, that's correct. There's been no application denied, which it does lead to some really interesting questions. I think it's also interesting to note that there's been no indication denied. So I believe there may be over 150 indications now that the data's been updated. A really, really wide range of indications have been prescribed medicinal cannabis. Even from the practitioners within the study, they told me things that they wouldn't expect medicinal cannabis to work on, such as dermatology related conditions. They had got approved prescriptions and perceived it to be helpful. So it's interesting to consider that the breadth of indications people are using medicinal cannabis for is very, very wide. Pretty much any indication you can think of, I think I could find on the TGA data dashboard.
Yeah. We had somebody ask, is there people, you did sort of touch on this, but people going to look for medicinal cannabis, and did you find it was a general thing that they had to have exhausted other areas of treatment before medicinal cannabis would be prescribed, or was that sort of just a few prescribers?
Yeah, I'm not sure if that came up too often. I know that is, of course, the intention of medicinal cannabis, that all other treatment options have been tested and exhausted. Again, I'm cautious about what I say from what those particular practitioners described, but there was generally a view that they felt that that condition was not necessary, and they hoped that they could use medicinal cannabis as a first-line treatment because they found it so effective and so safe from their perception compared to other treatment options. Although, of course, this was the exact opposite for some of the other practitioners in the study, who really only saw it as a very last resort. We're going to try something approach.
Yeah.
Mm.
Okay. We do have, does somebody, do medicinal cannabis have pharmaceutical reps? So like other prescribers, do they provide the treatment and the training, etc., or where are they going for training and sort of understanding the products? And
Yeah, it's a good question. They do have pharmaceutical reps, and I heard from some practitioners who had been approached by pharmaceutical reps. It's difficult to answer the question about where people are going for training. There is a couple specific programs in Australia which have recently come about. They're usually online self-based programs. You can find them quite easily from Googling them. And from what I understand, there are 2 or 3 big medicinal cannabis learning organizations who I think are run by practitioners in the field. So it seems like those online trainings are where a lot of practitioners are now getting their knowledge from, which it's interesting because I'm not sure if those courses are endorsed by a particular government funded scheme or have any credentials just to ensure that they're giving safe, unbiased information.
yes.
But there's definitely a few dominant training courses which have been popping up available online.
Yeah. Do you think that, or just in sort of your discussions, do you think that if we had a model more in line sort of with Canada and the USA, where doctors sort of gave a license or a permission to use medicinal cannabis, and then they go to a specialist dispensary where there is somebody that has knowledge on the different products and sort of can talk people through that, do you think that would be more favourable by doctors, that they didn't have to sort of know all the products and know which one? They could just say, yes, I think this would work, go see the specialist dispensary sort of thing?
Yeah, it's interesting to think about, and it's so interesting to capture kind of the effects of these divergent regulatory approaches. I personally feel from the conversations that I've had that these ideas of professional identity would still be really relevant, and some or potentially a majority of doctors may be reluctant to provide that endorsement that medicinal cannabis could be a potential effective treatment option without that really strong data that supports it from randomized controlled trials.
Mm-hmm.
Although, yeah, there may be a subset of practitioners that would find that to be a really accessible option for patients, and also kind of in line with their experience-based approach to practicing, where they may feel that medicinal cannabis does provide benefits for patients, even though the evidence base is still developing. So we might see more uptake of recommending medicinal cannabis if there wasn't that need for getting approval and personally providing that care.
Mm-hmm.
Mm.
Cool. So you mentioned too the fragmentation of care when you have the medicinal cannabis specialists versus the GP, maybe that's prescribing. Did you find that there was any specialist providers that were also doing sort of general care, like a holistic care as well?
Yeah, a lot of them did have their own personal medicinal cannabis business alongside their GP practice or their specialist practice, their primary workplace. And many of them did describe themselves as holistic practitioners, although for a couple of practitioners in the study, it was quite a good business to be a medicinal cannabis prescriber, and they found that they had a lot of patient demand. So they actually did choose medicinal cannabis to be their primary area of work, and they ceased their other employment. So it seemed to be a bit of a split, with some people continuing their regular practice but having a couple days solely for medicinal cannabis, and other people wishing to make it their entire career, essentially.
Yeah, yeah. We sort of talked about the regulation before, and but
Yeah.
were there any sort of specific discussion around that, about how practitioners perceive the current regulatory framework governing it? Yeah.
Yeah, that's interesting. I'm just trying to think back if that came up. I think the barriers in terms of it being an unapproved medicine and being obviously there was for the practitioners who had quite a lot of experience prescribing, there was a view that it was just a little bit silly that they had to apply to prescribe every time, and that the medicine was so expensive to the
Mm,
point where it did reduce equitable access to
yeah,
medicinal cannabis products. And that was seen as potentially associated with the stigma towards cannabis as a medicine. There was that general view that was thrown out, which we didn't quite end up documenting in the final paper just because of word limits.
yeah.
But yeah, for that subset of practitioners, it was seen as a little bit silly when they felt there was sufficient evidence that it was a really effective and useful treatment for patients and improved their quality of life overall.
Yeah. Was there, so when you were talking to the doctors, was there particular differences noted in their preference for prescribing around THC, CBD? So like were some only willing to provide CBD, or were there mixed?
There were a few. It seemed actually that the nurse practitioners were more willing to prescribe CBD only medicines, and they reported that they had seen quite good effects from their patients based on CBD medicine. Although many kind of described not knowing what would work for any given patient, and they really had to trial different kind of dosages and different products. And sometimes it was a CBD, sometimes it was a mix, sometimes it was primarily THC. They would really just trial it from what I heard and see what worked for the individual without, too much of a preference going in.
Yeah. Yeah.
Mm.
Along that sort of financial state,
Yeah.
as you say, it sort of promotes some inequality there. And
Mm.
people often find it difficult to come up with the regular money for ongoing issues. Was
Mm.
there sort of concerns around that and sort of de-prescribing, having to bring people off it? Um,
Yeah, that's such an interesting point. I actually remember one comment specifically from one practitioner who he felt that there were certain products that would be most effective for his clients, but he actually couldn't recommend those because they were more expensive
yeah,
than other products with a different composition. And that meant that he wasn't prescribing what he felt was the most effective treatment approach only because of the costs associated with it, which is, yeah, it's a significant concern for equitable and effective access. There was also a practitioner who really, really did believe in the benefits of medicinal cannabis,
mhm,
but he wasn't able to recommend it to any of his patients only because of the area that he worked in, the geographic area. So it definitely does seem to be a source of inequality currently in the medical system.
we're just about out of time, and we've got more questions coming through. But there is
Okay.
one particular one which I thought was we should ask, and that's from the palliative care sector. Was there any sort of prescribing coming into that area now?
Yeah, I wish that I could provide specific insight into that. I don't believe we spoke to any palliative care practitioners specifically, although I know that there is some qualitative research specifically looking at that population, which I'd be happy to email through, or it is in my reference list for the paper if you wanted to have a look. I wish that I could provide specific insights from this research, but unfortunately, we didn't capture that population.
Well, thank you very much again, Olivia. That has you can see all these questions coming in that
Oh, wow.
it's something that everybody's sort of interested in, and especially in the AOD field, and how it's managing and how it can be best used and everything like that. So thank you very much for bringing that to us.